Thank you so much for joining us today, Bronte. I'm stoked to pick your brain about some of these topics. Bronte and I met recently, and as soon as you started speaking to us at Newcastle Performance Physio, I was like, wow, I need to get you on our podcast because I feel like you just have so much knowledge to share and you're so well across, this area, which is such an important topic. And I was thinking about it today. I was like, is this taboo or have we moved past this as being taboo? And I'm interested to hear your thoughts on that. But yeah, thanks so much for joining us, Bronte. Tell us about yourself and how you got to sort of where you are now.
Thank you so much for having me, Kelly and Blake. It's really an honor, to be honest, to be asked to join on your podcast. So I always struggle with this telling people about myself and what I do, but I'll try my very best. So yes, my name's Bronte. I'm 25 years old, about to turn 26 in a month's time. I'm the director of Nourished Not Deprived. We're a multidisciplinary organisation with a team of counsellors, psychologists, occupational therapists and dietitians. I'm a dietitian by trade, and I developed the company because of my own experience with bulimia nervosa when I was young. So when I was younger, I developed an eating disorder due to multifaceted reasonings, which we can talk today about why eating disorders do develop. But one being that my father was quite unwell when I was young, and because he was quite unwell, I felt a little bit out of control in, I suppose, my development and upbringing. So then the eating disorder developed, and when I moved through treatment, and I actually had to put myself through recovery, unfortunately, because we couldn't find assistance in that space, I basically made a vow to myself that I would prevent anyone from going through what I had been through. Or support them in that space that I felt very unsupported in. It's not that my parents didn't support me, it's just that the education wasn't there. And I think, Kelly, to bring back to your point before on is it taboo or not, I think it's just lack of education and no one's really talking about it. I think it's becoming more prominent on social media to discuss body image and body positivity and weight stigma and that sort of thing, which is beautiful. And there is that movement towards like the no diet culture and that sort of thing. But again, then we end up sort of skewing into, okay, well, no one's allowed to diet and nobody's allowed to calorie count. I see this sort of very big, diverse group of practitioners where you'll sit on one end of the fence or on the other end of the fence. And I like to sit somewhere in the middle. But yeah, and I guess I spend most of my day developing the organisation and assisting our patients, and we're a team of 12 now. And as I said, we're a telehealth-based organisation, so we have patients Australia-wide, which is really cool.
That's awesome. And did you study in Newcastle? Is that where you did your degree?
Yeah, I did. I studied it at Callaghan. I grew up on the Central Coast and I commuted to Newcastle. And for some reason, it always felt like home being here in Newey. And then, about 2 years ago, I moved to Adamstown and now I'm living in New Lambton. And yeah, I've loved it. I don't think I'll ever move from Newcastle, to be honest. Can't see myself moving.
That's awesome. And like, that's amazing that you set up this business to, help others like you wish you were able to be supported during that time. And I mean, you already have touched on a couple of the different sort of types of eating disorders or disordered eating. And there's so many. Like the other day when you were talking to us, there was more that I have even heard of. And I guess there's like such a big range of people that it can affect as well. So the one that you were talking to us about was particularly in people with, autism spectrum disorder, which I thought was really interesting because that's not something that I've heard of before. But what are some of the more common types of eating disorders that you tend to see?
So because you told me that you were going to be asking this question, I actually created a list. So I'll read off the list. So anorexia nervosa is one of them, bulimia nervosa, binge eating disorder, other specified feeding and eating disorders. There's picker, which is a very interesting one. Some pregnant women will actually develop picker. It's that drive to want to consume like dirt or ice, so things that you shouldn't be consuming.
Interesting.
Yeah, very interesting. And then we've got rumination disorder, which most people don't really hear about that one either. It's when you'll chew and then spit out the food. We've got avoidant restrictive food intake disorder, which is that the eating disorder that's correlated with ASD, which I mentioned to you the other day. So autism, or those that have autism will usually somewhat develop some form of well, not usually, but you'll see that eating disorder within that subgroup and that population. Then we have unspecified feeding and eating disorder, and then there's two others, which is muscle dysmorphia and orthorexia nervosa as well. So there's a lot.
Crazy. So many more than I even imagined there could be. Have you heard of half of those, Blake?
No, I was just about to ask, like, how recent have those conditions kind of come to light and people being able to identify them? And I wanted to ask before, you guys were in a good conversation, when, back 10, 15, 20 years ago, what was the kind of treatment for people with eating disorders? There's two parts to that question.
Yeah, so I suppose in terms of development of treatment with any form of mental health disorder, it's always chopping and changing. But in the most recent years, in terms of most common treatment modalities, we'll see cognitive behavioural therapy being utilised for things like anorexia nervosa, bulimia nervosa, and binge eating disorder. Then the other ones, in terms of their prevalence and when they've just started to become recognised, I actually don't know. I only know in terms of my training in the field. I don't know when they were, I suppose, identified, but I haven't really heard anyone say that they've only just recently been identified. I've always known within my practice, and I know that most of my dietitians have known about these for quite a long period of time. I think it's just, again, that lack of discussion in the community or discussion within other allied health practices as well, as to why it becomes a bit of a shock that there are so many that people suffer with. But they are quite common mental health ailments, and that's what eating disorders are, but they're just not discussed, I suppose, as readily as they should be.
Yeah, we talk about, like, especially on the podcast and where we work, the multidisciplinary approach and having a good understanding of what other health professions do, because it's so important, because very, very rarely can we be everything to everyone, and knowing about what a physio does or an orthopedic surgeon, a dietitian, those kind of things are so important. I think now, just reflecting on hearing you say that, it's not that it's new, it's just that something that I've been completely unaware of. And we do this podcast, where I was just saying before off air, we're coming up to 90 episodes, and we follow lots of people on social media, and still for me, it's relatively new information. So I'm assuming for most people, it's going to be relatively new, which is awesome, because new information is great.
Yeah, absolutely. And I think working within that multidisciplinary team at Nourished as well, there are things that the other practitioners will mention that are common knowledge to them, and I'll have absolutely no idea about it. So it is really nice to work within that multidisciplinary team to be able to talk about things that are common knowledge for, the allied health practitioner working in that space, but aren't for the others, and things that you think other people will know about, particularly other practitioners, they really don't, even down to just general nutrition knowledge. I'll have clients that are other allied health practitioners, and they have absolutely no idea about, the general macronutrient distribution or anything like that. So I think it's just the lack of awareness there and the lack of education, really.
Yeah.
Across all those different types, would you say that management or treatment of them is quite similar across them, or is it quite a different approach depending on what different sort of subcategory of eating disorder someone is experiencing?
So I guess in terms of eating disorder treatment, there's a certain structure that you can follow where you stabilize, you look at where the eating disorder has occurred from, or where it has developed from. Is it from, a past trauma? Is it from a current trauma? Is there environmental factors? Is there another dual diagnosis of a mental health disorder? And then you'll look to treat that as well. But you must stabilize first. And if you don't stabilize, then the mental health treatment will not be optimized, because someone's cognition will not be at an optimal amount, someone's cognition will not be there, so they won't be able to take in the therapy. And then in terms of, I suppose, how the treatment runs, it is really dependent on the eating disorder that's present. So someone who has been referred for, say, ARFID, which is a sensory processing disorder, usually will need OT intervention or some form of sensory processing intervention, rather than someone who's been diagnosed with bulimia nervosa. They might need, cognitive behavioural therapy alongside fear food intervention. Does that make sense? So you can follow a similar structure in terms of like stabilize, look at where the mental health disorder has occurred from, and then optimize treatment there. And it's usually very individualized what happens with the patient as well. Sometimes you can push a little bit too hard and they can tend to fall off. So you need to be very careful with how you follow treatment and utilize different treatment strategies as well.
Yeah.
Bronte, you mentioned that does it fit under the mental health category? Like, is it a mental health disorder, or are there conditions where there's physiological changes that someone just has that relationship with? Or I'm probably coming from this at a primary school level compared to your knowledge, and it sounds very simple, but I've heard you mention that a few times. I just wanted to clarify for the listeners.
No, yeah,
and myself.
They're a mental health disorder. That's their category. So they fall into the DSM-5. So yeah, they are classified as a mental health disorder, which a lot of people don't know about.
Yeah.
And as I said before, so anorexia nervosa, has the highest mortality rate for any mental health disorders. So the discussion on this does need to, it is quite serious, and we do need to be talking about it more because, they do have one of the highest mortality rates for mental health disorders.
I think that's so important too, because you can think of like those people that are a bit sort of old school, and they might comment on people being like, oh, they just need to eat more. And it's like, no, there is so many more layers to it than that. Like, there is so many barriers to this person just being able to eat more that need to be unpacked and unraveled first. And yeah, I guess like when it is more of a mental health disorder, that's why it becomes such a tricky area to manage and treat, I suppose.
Yeah, absolutely. And I think as well, mentioning that decreases the stigma, because there is that stigma of, why don't you just eat, or why don't you just stop eating? On both ends of the spectrum, someone who is quite overweight, I usually see that stigma around, well, they're lazy and they need to exercise more, and why can't they just stop eating?
Yes.
And majority of the time it's a binge eating disorder, or there are medication provisions that have been set in place by that person's medical provider that is causing heightened appetite and causing some form of disordered eating behavior. And then we're still seeing people shame or fat shame for someone who can't stop eating because they're lazy. And that's just not the case. No one wants to be uncomfortable with their weight. Nobody wants to eat to the point of feeling unwell. I think we need to have a little bit more empathy for what someone might be experiencing and think a little bit outside the box. And I still see health practitioners who don't think like this, and I wish there would be more of them, because I think it's our responsibility as a health practitioner to allow a patient to feel safe in their experience, in whatever that experience is, so that we can get to the bottom of, why they are uncomfortable, why their quality of life is not to where they want it to be at the moment.
The one that frustrates me the most is on social media. We talk to anyone, they just say, oh, it's very, very simple. It's just calories in versus calories out. That's all it is. Once you get that and understand that, you'll be fine. And it's like, you cannot believe that it is that simple. My God.
No, and eating is certainly not that simple. I mean,
Yeah.
I find that a lot of the time, say someone's not referred to us for eating disorders or disordered eating, it's not as simple as saying eat 3 meals. That's not what someone's life is about. Sometimes it's not easy to have a breakfast, and you need to come up with some really weird and wonderful strategies to just get someone to eat a meal. It's not as simple as just count calories. A lot of people don't have that privilege, I find.
What are there any identified risk factors for developing an eating disorder? And I guess from a clinical standpoint, for clinicians listening to this, which is the majority of the listeners, like side effects that people can pick up on, both physiological and, in the way that they're speaking and discussing and things like that?
Yeah, so I suppose risk factors. So you want to think about biological, psychological, and social. So biological risk factors would be having a close relative, mum, family member, carer, brother or sister with an ED or a mental health condition that increases risk. A history of dieting within the family or yourself. Type 2 diabetes is an interesting one. So we see a quarter of females that are diagnosed with type 1 diabetes develop an eating disorder. So that's one to keep an eye out on. High body weight as a child, and even low body weight as well. are risk factors. And then you look at psychological. So any form of anxiety disorder, if you have like a type A type of personality, perfectionistic in some manner, which a lot of health professionals do. So that's always something to look out for. Body image dissatisfaction. Someone who has braces as well as had braces, you usually see young women who they'll have braces, their body weight will drop, they'll start to receive a little bit of attention, and then that's how an eating disorder can tend to develop as well. Any mental health ailment, so you usually see that dual presentation with another mental health ailment, because an eating disorder is usually the brain's way of trying to control in a situation that it feels out of control, whether that be a mental health illness or environmental. The neurodiverse population as well. And although we don't have a framework in terms of eating disorder treatment in the neurodiverse population, to understand the prevalence in the neurodiverse population, we have to think about gender identity within this subgroup. And we know that those that are neurodiverse, they are 7 times more likely to identify as transgender or gender non-binary, which in transgender and gender non-binary subgroups, we see individuals having higher risks of body dissatisfaction and trying to change their body shape, which is a risk factor. So you could correlate that to neurodiverse individuals being almost 7 times more likely to acquire some form of eating disorder. So that's always a population that I will screen quite regularly. And I think it needs to be everyone needs to be made aware as well that in the neurodiverse population, if someone from the NDIS is presenting to your practice, an eating disorder might not have been diagnosed or even looked into at all, because the NDIS doesn't fund for eating disorders. And then when we're looking at Medicare, unfortunately, there's only 3 types of eating disorders that are funded for Medicare, so anorexia nervosa, binge eating, and bulimia. So if someone is presenting neurodiverse with ARFID, it may not have even gone up onto anyone's radar that this might be something that is not the primary diagnosis, but something that's happening in the background. So I always ask my practitioners to just really be aware of, is there an ED present that hasn't even been considered yet because of the lack of funding in this population?
Sorry.
So you go.
I was going to say, that's the perfect kind of segue into, if it hasn't, what can people do? And like I said, I'm sure that's what you're about to answer, kind of the signs and symptoms, and then questions and clinical questions that you can kind of ask. And I'd love to ask you how, I guess, dealing with adults and I guess people over the age of kind of 15 to 16 that are, comfortable and can have a coherent conversation with, but younger people and with parents and things present, and kind of having that discussion. How do you recommend people to kind of ask those questions and deal with that? Because that's and I had this last week with someone with a bone injury, and the mum had mentioned to me that they'd struggled with dietitians in the past, and it's a serious problem. And it was hard to kind of discuss that in that dynamic of myself, patient who was a younger person, and mum.
Yeah, so I guess that's actually a really good example. So tell me, what do you mean by they struggled with a dietitian in the past?
Well, they said to me that they had seen a dietitian and that didn't go down very well. They'd identified that they really struggle with fueling properly. This is their second bone stress injury, and yeah, that was kind of it. And we focused on many things but that's something that I think that would be very hard to have that discussion in that dynamic. And that was only I've only seen them a couple of times, but I wouldn't certainly press that until I was kind of, I guess, a bit more of a therapeutic relationship, but still a hard conversation to have.
Yeah, absolutely. And that's a really good point. So obviously building a therapeutic relationship with that patient and the family is really important before you try to push any other services. I find that if you try to push before you've built that trust, it somewhat is usually dismissed unless it's unless they are already in that stage of change to want to progress to, seeing that therapist. So I suppose there's a level of barrier there because they've already had a poor encounter with the dietitian previously. And I think when I met with Kelly's team last week, we had a similar situation happen. So what I usually do, and I actually put it into a little bit of an acronym, ask, listen, learn, validate, and lead. So ALLVL. It's something that I do with all of my patients. So I will ask them what their goals are. and what they want to achieve. So when the patient or the mum, or was it mum that was you? Yeah. So when the patient or the mum come to you, they obviously have a goal. So if you're noticing an issue and you don't know how to bring it up with them, I'll ask them what their goals are. And then the goals would probably be to not be in pain and perform more optimally, correct? And then you'll listen to that, and then you'll ask a little bit more, okay, so you're not at the moment being able to, optimize training because you're injured and you're in pain every day, and we want to get you to the point that you're not. I can completely understand how in the past, you've seen a dietitian that hasn't suited your needs, and just because they have that degree doesn't mean that they're always the one that will be best suited to you. It's like finding a really good therapist. In any circumstance, you need to connect with them, and they might not have been the right one for you. So in that sense, you're validating. So that's part of that acronym. And then lead. So you as the health practitioner can then lead what you think would be appropriate. So you can always say, I want to get you to that point where, you're out of pain and you're optimizing your performance, and you're getting to the point where you want to get to in your therapy. And I really think that it would be appropriate if we had a dietitian that I trust, that I know has done a really good job in the past, to get you to that point and to help us in an area that I'm not educated in. So you've asked them what their goals are, and you've put that front of mind. You've listened to their experience. You've learned about their experience. You've validated it. And then you've led as the clinician. And I think a really good point in that, Blake, is, again, making sure that when you do this, because you can always ask, listen, learn, validate. You should be doing that throughout your therapy anyway. The time in which you lead needs to be timed when you know that they are trustworthy of your opinion, and you can feel that, they have that relationship with you. And I think that's really important. But that's what I would have done. And I think always, validating in that space, because unfortunately, look, it's a common rhetoric that the dietitian wasn't a good appointment and the dietitian wasn't great. And that's something that I'm trying to change here at Nourished. If you have a look at our website, it's very colourful and bright. And that's how I want people to feel when they leave an appointment with us, particularly because dietitians tend to have that stigma around the appointment. I've heard this many a time. So does that make sense? That's what I would have done.
Yeah, it does.
Yeah,
it does. And it's hard for them, I'd imagine. You always got the benefit of hindsight, because some people just aren't ready for that information. I can imagine the dynamic between mum and child is always tricky when it comes to that, and especially in this person who did a sport where they are spending a lot of time doing the sport, upwards of 15 to 20 hours, and it's a difficult thing when weight and whatnot is important. And for clinicians, what advice do you have for them? Clinical questions and also signs and symptoms to possibly pick up on that in a consult, and ones that may be more passive and more active?
So I think in your general intake form, so in that initial appointment, you should be asking about that patient's mental health and diet anyway. So you should be asking, are they eating regularly? You should be getting a good intake on, maybe a 24-hour or a week. Not a 24-hour, sorry, like a couple of days worth of intake. 24-hour recall I don't necessarily love, because it can be a skewed result. So a couple of days, maybe a weekend variation, just asking how they feel about, their relationship with food. Do they feel nice and energized throughout the day? I'm sure that I actually wouldn't know in terms of physiotherapy and exercise physiology. Do you guys do a bit of a food intake and a mental health assessment in that initial? I know that I have my other clinicians and my OTs and psychs do it, but
we do ask if there's any are you experiencing any mental health issues. We don't, in our initial intake, we don't ask about food. I tend to ask it during our initial consult, but not in their intake form. I'm not sure about Blake.
Yeah,
sorry,
I did mean similar.
Yeah, I did mean in that initial appointment. Sorry.
Oh, sorry. Yep. And particularly like endurance athletes or, maybe younger athletes where body image might be an issue in their sport. That's when it's probably, I'll probe a little bit further.
I think there's a really good point on that where younger athletes tend to be they're watched over very well, and then we tend to ignore older populations. So I talk about this in one of my modules 12 to 25 is where we tend to see people present with an ED or some form of disordered eating. But I would encourage clinicians to consider why that is. And it's because they're usually at home or with carers or with a lot of people around them watching over their behaviour. When someone's 25 and up, usually maybe you're out of home. If you've moved out, you're usually quite individualized in, what you do day to day. You're an adult now. It's time to, suck things up and get on with it. And that tends to be the rhetoric, 25 and up. And I think that we still need to be aware that I have patients presenting at 60 years of age with an ED that are excessively exercising. It's just something to consider as well in your practice. But back to the other point on, I suppose, signs and symptoms. So if you're asking about food, if they're skipping meals, if they're overhydrating, so you fall into the trap of, electrolyte imbalances if they are overhydrating. And, if you have any hydration queries, you can always refer to a dietitian for that anyway, but overhydration tends to be a sign and symptom. And then if you're asking about menstruation as well, so amenorrhea, lack of menstrual cycle, is a sign and a symptom. Stress fractures, which is the one that Blake mentioned before. We know that osteoporosis and osteopenia are a risk factor of EDs. Unfortunately, I actually have osteoporosis following my eating disorder, so that's not fun. And I actually use that as a bit of a push for some of my patients when we've developed that therapeutic relationship. It does actually happen and I have it, so let's prevent that for you. And then I suppose in terms of mental health, excessive moodiness, irritability, and around meal times as well. So you can always query, you can ask a little bit more about their mental health. So instead of saying, because if I was a 14-year-old and I was asked, how's your mental health? I don't know, it's okay. So I would ask a little bit more, how have you been feeling at school lately? Have you got, tell me about your best friend at school. What's their name? Like just asking a few little things. And if they say things like, I don't really have a best friend, or we've had a fight lately, and then you query a little bit more and they're having fights around food maybe, because that can occur. You'll tend to see patients very angry at other people for being able to eat regularly and normally, usually fighting with their partners as well about, their food intake, etc. And then I suppose just generally, if you've been seeing them for quite a while, if you're finding that their performance is not improving, they're fatigued, they're low in energy, similar to the patient that one of your colleagues mentioned the other week, Kelly, that hadn't eaten all day. She was quite lightheaded and faint, things like that.
Yeah. And I was thinking in schooling groups and I guess training groups and things like that, do you find that it's, I don't know if contagious is the right word, but is that, I know we were talking about sort of risk factors, is it if you're in a group where it's sort of prevalent, is it more likely for that to happen?
Absolutely. So we conform, right? We conform to what the community is doing, and we see this on social media all the time. Everyone's mimicking what everyone else is doing, and I think there's a saying, you become a reflection of the 5 closest people to you. It's true. And if you're in a family environment that is quite tumultuous in their relationship with food. Similarly, if you're in a friendship group or you're at a school that has quite prevalent dieting behavior, or maybe even teachers that are inflicting, body dissatisfaction or shaming onto the children, then absolutely. It becomes more prevalent. And I say that for people to very much recognise that there are teachers and principals and schools that still have lack of education and are still saying some very inappropriate things, to the children. So it is something to be aware of. I did also just think of another sign or symptom that's quite interesting. I find it quite funny because I had it happen to me. There's something called carotenemia, which is an excessive amounts of carotenoids, which is found in, your orange vegetables. The palms of your hands turn orange and the balls of your feet can turn orange, and it's usually accompanied with you get quite itchy as well, but they're quite quite orange, and you can tell. When I was in my first year of university, when I was still on and off with my ED and just getting to the back end of recovery, my palms were bright orange, and I had no idea why. This can actually be attributed to bulimia and anorexia nervosa, because you're excessively eating vegetables, particularly carrots. You'll see those with anorexia continuously eating carrots. And I laugh because everyone stared at me in the class when this came up on the screen. And yeah, it's also a sign and symptom. So if you're seeing a patient with quite bright orange hands, it can also be, a sign or symptom of, untreated or unmanaged diabetes and like hypothyroidism and that sort of thing. So anyway, it's a warning sign to, send to GP. But yeah, that's another one.
That's interesting.
Yeah, that's really interesting. Different.
We were talking just before about teachers in that sort of environment not having a great education or awareness around the space. I mean, us as health professionals, I in particular, I'm very conscious of the language that I'm using. I know Blake's much the same. What is your advice to say, like, health professionals, coaches, athletes, to be a positive role model to those around them who might be, suffering from an eating disorder or body image issues or even at risk of it, say?
Yeah, absolutely. So neutral language around food. So I ban the use of good and bad foods within Nourish. There is no good or bad foods. It is all contextual as to whether a choice of food is good or bad or optimal or not optimal. For instance, if you feel like having a piece of cake out with your friends, or even just have a piece of cake late at night in bed because you've not had a great day, that's okay. You're actually allowed to do that, and you don't need to feel guilty, particularly if it's not causing any, poor health issues or making you feel unwell. If it is, then that's another question as to why that would make you feel unwell. Are you only eating cake? And if you're only eating cake, then okay, that needs to be addressed. But it's not the cake that's the bad issue, or the bad choice. It's the lack thereof nutrients in other food groups that you should also be consuming if you have availability to that food group. Similarly, salads or apples, let's use apples. Apples are seen as a really good food, right? But if you're only eating apples every meal, or you're excessively eating apples, then that is also not a great choice and can lead to nutrient deficiencies and malnourishment in other ways. So it's contextual. And we don't want to create moral value around food. You're not bad for eating something, and you're not good for eating something. You are the human that you are outside of what you eat. What I like to do is I tell my practitioners to use nutrient-rich food or less nutrient-rich food. Both are fine. Or nutrient-dense, less nutrient-dense. And I know it's a little bit of a mouthful, and I know it's a little bit annoying. And if you are a practitioner or a person that does use these, words, good and bad foods, or that was bad for me, or that's naughty, or you shouldn't be having that, you'll have some trouble changing the terminology. But it's very much worth it, not only for your patients, but also for you. You don't want to create a moral value around food. It's not nice, being back to back with 6 patients, feeling quite stressed, and then wanting, a chocolate, and then guilting yourself, and then going back into clinic and feeling bad about the chocolate you ate. I mean, nobody wants to be doing that. So it's not just about your patients as much as it's also about you too.
Yeah, we see that in our with good or bad exercises, good or bad shoes, good or bad everything. I mean, yeah, it's just and it's I think everywhere, and it's certainly becoming more well known, which is great. You know what, Blake? It's almost I attribute it to when I had a back injury. I was told to not exercise at all, and similarly, if someone has diabetes, they're told to not, from health professionals that aren't versed in this area, they're told to not eat carbohydrates altogether. It's not about reducing carbohydrates altogether. It's about managing when you eat it, and it's about looking at how much you're having at what point. And similarly with the exercises that you still want to be doing, it's just about modifying what you're doing if you do have an injury. Is that correct?
Yeah. And that would be similar again to, my understanding is that if you've got an eating disorder, the advice is not to stop exercise either. Like, you can continue to do some form of exercise as well, as long as it's sort of managed and someone's overseeing the dose, I suppose. Is that right?
Yeah, so again, it's very individualized and it depends how progressive the ED is. But usually mild forms of exercise are okay. Mild forms of movement are still okay. You don't want someone laying in bed all day. And, we know that exercise still releases endorphins and it's still good for the body to be moving. So it's usually, again, just monitoring what type of exercise and, again, overseeing it and not just doing the same thing that we were doing that was causing harm. It's just chopping and changing and pivoting to something that's a little bit more appropriate at that point in time. And that's not to say that patient can't go back to what they were doing before. And I always say this to our patients as well. It's not to say that you can't ever change your body composition again. It's not to say that, you're not allowed to lose weight ever again. That's not the point. The point is that right now you're mentally unwell and right now you can't. And when you're feeling better again, and when you are mentally well, and when you are stable, then maybe we can address that again. But at this point in time, right now for what you need, that's not appropriate. And I think outlining that to patients as well is really important. This is not necessarily going to be a forever thing. This is just what you need right now.
Is it true that when if you're younger, let's say, and I guess it varies between females and males and of the person, lots of factors, but generally speaking, if a younger person has, a form of ED and that isn't picked up or diagnosed and addressed, the longer term implications are things like reduced bone density, systemic health, they don't have a regular menstrual cycle, all those kinds of things. The implications for the long term are pretty clear. And I think the easy one for us would be, someone, and you were mentioning before, having reduced bone mineral density, like that's a huge risk factor for having a stress fracture and stress injuries to your bones when you're older. And that may have been for something when you're younger, not so much from right now.
Yeah, absolutely. So long-term implications of EDs can result in things like heart damage, osteoporosis, osteopenia, muscle weakness, and the heart damage can be irreversible. There are long-term health conditions that you want to get on top of it as quick as possible, really. And not only that, the impact on social life as well. Eating disorders don't just affect that patient. They affect everyone in that patient's life, including friends, family members, the allied health practitioners involved. Not affect, but, it does impact a lot of things economically and socially as well. So not only is it important to get on top of it as soon as possible because we want to prevent, long-term damage, but also we want the treatment to go as smoothly and as quickly as possible. And the longer something has been around, usually the longer it will take to recover from.
Yeah, that's full on, hey.
It is, and it is a lot, and I think that's why it's not discussed as readily as it should be, because it is quite a heavy topic. It's not nice to be talking about how, someone might have heart damage for, the rest of their life following not eating. But yeah.
And who's often having that conversation with the patient? Is it yourself, or is it the psychologist, or is it the doctor or sports doctor, or who do you think is usually having those really tough conversations, or all of you?
Yeah, it's a really good point. So I've made it my life's mission to go around to all of the medical centres and as many allied health organisations as possible to educate them on eating disorders, because the doctors are usually not educated in this space, and they're actually usually not educated in the space of being able to provide something called an eating disorder plan for their patients, which provides 20 rebated dietetic appointments and 40 psychology or mental health appointments. They're usually not the ones having that difficult discussion unless they are versed in that area, which we're very lucky at Nourished to have some doctors that are, but they are actually quite rare. And a lot of the time you'll find kickback from doctors where a dietitian will query a diagnosis, because unfortunately we can't diagnose. A psychologist or a doctor or a psychiatrist must. So dietitians will usually query. They'll send the patient to the doctor, and the doctor sometimes says, no, there's no eating disorder present. I'm not providing you with an EDP, but I'll provide you with a mental health care plan to see a psychologist for 10 appointments, which is just, it's not enough. And financial burden, if it's reduced, the patient will more likely engage in therapy because it's already hard enough It's already hard enough to go to therapy every week and tell someone how much you're struggling and ask for help. If we can reduce financial burden, then we're going to improve treatment progression or treatment engagement. But yes, unfortunately, it's not usually doctor. I'm finding, and I mean, I'm biased because I'm a dietitian, but I find that dietitians tend to pick up on it because we're asking about food more. My dietitians will tend to pick up on it more than my psychologists, just because we are, if it's one that hasn't been referred for ED, just because we are asking about food more. But that's not to say that psychologists don't pick up on it, specifically if they've been, trained in the area. But yeah, I'm generally finding that it's psychs and dietitians as opposed to doctors.
What does it take for a diagnosis? Like, I'm thinking of myself. Like, when I was in uni, I was trying to lose a bit of weight, and I was eating 60 grams of carbohydrates a day and training twice a day. And I think from this conversation, I'm thinking to myself, like, and I think back now, at the time, I was like, yeah, this is right. I'll just lose heaps of weight. And then now I look back on it and it was incredibly stupid. I don't know if that, like, what classifies someone to have a eating disorder, because I imagine, like with most things, and we used diabetes as an example, you can be pre-diabetic or not in the threshold for diabetic, but have all the signs and symptoms and all the, I guess, all the consequences that come with that. Is it similar with ED as well, where maybe you don't have the diagnosis, but you're very much close to the threshold and you've got all the signs and symptoms of someone that does?
Yeah, so you're basically talking about the differentiation between disordered eating and an eating disorder, and the only distinction is not falling into the classification of the DSM-5, that particular eating disorder. Now, I know that I mentioned all of the eating disorders before, but there are atypical presentations to those, which means that you haven't quite fallen into the certain level of maybe compensatory behaviours for bulimia nervosa, but you'll still be compensating, so you fall into an atypical. Or if you don't fall into the atypical, then you're usually diagnosed with just disordered eating. And I suppose the insidious part of this is, if you do not have a definitive diagnosis of an eating disorder, a lot of people don't take it very seriously, and it can still be just as serious as an eating disorder just because you don't fall into the classification. So yeah, in terms of being diagnosed, you need to fall into that specific classification of the DSM-5, and it's very different for every single eating disorder. It's really dependent. But yeah, that's usually the only distinction.
Yeah.
In like very body conscious sports, such as like running or gymnastics or dancing and things like that, what are some of the, I know we've already touched on sort of risk factors, but are there some specific risk factors that might be more sort of present in the sporting space that you see?
I suppose in the sporting space, the issue is that obsessive nature, usually with someone who wants to get to a certain level of performance or get to a certain goal, right? And to get to the top of the top, you're usually type A, you usually have to be obsessed with it. And that's okay, but it puts you at higher risk of acquiring disordered eating behaviors or mental health illnesses such as, OCD or anxiety-derived illnesses, which then puts you at higher risk of, an ED, and particularly because you're, so focused on performance, and that's usually attributed to focus on, body weight, particularly if you're looking at a sport that needs, weight drops and things like that. Your risk definitely increases. But I would say that athletes in general, because they are usually obsessed with what they're doing, they then can take their eating and what they're doing with that a little bit too far. And then that comes into the, I suppose, conversation of, well, what is too much? And, to get to the top, you need to do those things. And that's, I suppose, a completely different conversation. But at the end of the day, if it's causing you to become unwell and to have stress fractures and to be mentally tapped out from life, I would argue that any level of, medal or trophy is not worth risking losing your life for.
Yeah, and like if for say people listening, if you identify yourself as being in an environment where you are sort of at like at risk of potentially developing an eating disorder or disordered eating, what sort of advice would you have to that person to try and either pull themselves either out of it or remove themselves from that environment or seek help? What would you recommend?
Oh, such a difficult question, because I think some people would have the privilege to be able to remove themselves and others wouldn't, due to maybe parental pressure or finances, or, you know, there would be multifaceted reasonings. Maybe that's your only support network, but unfortunately they're quite toxic. I would say gold standard would be to connect with an organisation that is versed in this area and receive some guidance in terms of either setting boundaries with the people around you and being able to verbalise those boundaries, or maybe you do need to completely remove. But before removing, I would always try to set boundaries with those around you. If it is if the environment that you're in is putting you at risk because of other people's behaviour, you can have a discussion with them, and learning how to have that discussion, I think, is really important, because you don't want to blame or exacerbate what might be happening for the other people there. And obviously, if you want to maintain that relationship, it does need to be approached gently. But that would be my first, I suppose, attempt at decreasing that risk for you. And then, I suppose removal might be the next step. But engaging with someone that understands that area, whether that be a dietitian that has eating disorder experience, or a psychologist, or a counsellor, or maybe even a friend that you know has been through that similar experience, and you need to just open up and discuss that with them. That would be my advice.
That's great advice. And then, like, on a similar sort of note, like if you're a friend or a family member that's observing someone that you think could be dealing with an eating disorder or disordered eating, or if you at least want to sort of open up the conversation, like what is your advice to friends and family members who have someone close to them that's struggling?
Yeah, this is a really hard one, and you guys asked me this last week and I hate answering this because sometimes it's not the answer that people want to hear. It's similar to what I said before in terms of asking and listening and learning and validating. You can identify that there is something going on with someone in their life, and this doesn't have to be in relation to an eating disorder. It can be any mental health illness, maybe a toxic relationship, anything. There could be something that you know is not right. Unless they are open to change, unless they are willing to listen, you can't do anything. So what I would always advise is to create a support network for that person. Just ask them how they're feeling, and if they don't want to open up to you about that certain topic, or they don't bring it up with you, you can always say, hey, I've just realized that, you know, this might be going on for you at the moment. I just want you to know that I'm here as a safe person to open up to if you need some support in that space. I know this might be a little bit, you know, left field, but I would love to be able to support you if you need it. And they can either deny that anything is happening, they can decline it, or maybe that might give them the opportunity to actually go, hey, yeah, I need someone to talk to, and they just needed someone to notice. Sometimes, though, they're going to decline and they're not going to want to talk about it, and that's okay. As long as they're not an adolescent. And if they are an adolescent, then obviously that becomes parent or carer's responsibility to get them the help that they need. And it becomes, a mandatory report if you are a practitioner, etc., if they are in harm's way. But yeah, if it's an adult or an adult friend or partner, then you need to create space. And if they're not open to it, then just keep creating that space for them. Try not to take too much on board if you've created that space, because I know that a lot of guilt can occur from that as well. But it's not your job to save someone who is not ready to be saved.
It's hard. It's hard when you care and you want to help, I'd imagine. But they've got to be ready to hear it.
I always attribute this to my parents, or not my parents, sorry, my netball team identifying with me when I was younger that there was something wrong with me, and I told them all to piss off. So, and I just wasn't ready. And they tried, and I got really angry at them, and I didn't want them to notice anything because I was fine in my head, and I wasn't. But I always think back to that time that they all had a bit of an intervention with me, and I didn't want to hear it.
Well, do you ever get patients that you're like trying to help that are still sort of in that headspace or mindset? So how are you approaching that? Is it just a waiting game until they're ready, or are you trying to sort of question them more to get them to realize that maybe they do want help, or get them to appreciate that they need help? Or what do you think is your...
Yeah, absolutely. So I guess usually if someone is presenting to us in a not ready to change stage, they've been referred for something else. Usually I can attribute the goal that they have from that referral to treating an ED or a potential. But I'll always just ask, how are you feeling about, potentially exploring this? Is it affecting your day-to-day? And usually after I've asked them all of my prompting questions and they're low energy, they're constipated, they're moody, they've broken up with their partner again for the 10th time, they're feeling horrible, they're crying to me, I'll usually say, okay, what do we think we should do? And when they get to that point where, it's really affecting their life, they'll usually say, I think we need to engage. And I think that usually happens with us here at Nourished, because we don't push, and we don't say we need to get you into treatment now and this is the only option. And you don't want to scare someone off. You want to let them know that you're here to support. If it becomes, a self-harm risk, then obviously that's different. But it doesn't usually get to that point unless it's gone untreated for a very long time, and usually they're referred to psych anyway for things like that. But yeah, I suppose, again, just supporting, creating space, questioning, and usually letting the patient come to the conclusion that they need to seek the treatment. I'll always ask, what do you think we should do? I actually do that in a lot of my therapy after I give general education and maybe they haven't done what I've asked them to do for the 10th time. I'll say, okay, well, I'm out of ideas. You tell me. And then they'll usually come up with something really good, because most people know what they need. They just need prompting.
Yeah.
Outside of that person, so someone who is aware that they have a problem that needs to be addressed, would you say it's a similar approach, or your role is it food plans or like education? Like what is your main role to help someone through the journey of an eating disorder?
Yeah, so usually first you stabilize. So you have to, if they're restricting, you increase, and they usually are in some way. So you increase nutritional intake and you get them to a stable level of appropriate energy and macronutrient intake.
Right, that's what I meant by stabilize.
That's what I meant. Sorry. Yeah, sorry. You could have, just ask me if I say something interesting. Sometimes I use words that don't make sense. So yeah, so stabilize their nutrition intake, and then also their weight as well. So trying to get them to a point that's quite a stable weight so that they're not underweight anymore, whilst concurrently challenging their current food beliefs. And I find that when you educate someone and you continue to educate and you advise them that you can use this education to argue with what your brain is going to tell you when you leave this session. A lot of what we'll do is also educate on what's going on. I had a patient actually present last week, and she has anorexia nervosa, and we did some education on what anorexia nervosa actually is. So now she understands that the reason she feels like she's arguing with herself all of the time is because she's actually arguing with another side of her brain. So we externalize the ED. You are not that thought. You are this person, and then your eating disorder is over here, and your eating disorder is always trying to cause harm. It's quite manipulative. It will pretend like it has your best interest at heart, but it usually ends up making you feel either like you've got so much control over your life or you have absolutely none. And just teaching that person to externalize themselves from that ED as well. And then usually looking into, fear food work as well, maybe some food introduction. Maybe we'll eat that food with the patient as well and show them that nothing will happen because they build up, such anxiety around, weight gain from certain foods that they won't even touch it. They won't go near it. And then continuing on to try to create structure within their mealtime, variety within their meals. And then also in terms of, I suppose, gold standard treatment, you would want them linked with a psychologist to either assess any environmental issues that are going on or past trauma, current mental health conditions, dual diagnoses, that sort of thing, to support them in that space where a dietitian is not appropriately qualified to do. And then just continuing treatment with whatever comes up. And I suppose in terms of like bulimia and binge eating, you would be addressing the impulsivity as well and where that comes from and why it's occurring. So for instance, if someone was referred for binge eating, you would be looking at, okay, what's actually triggering a binge response? Is it emotional regulation? Do you have ADHD and it's a dopamine desire? Have you not eaten all day and you're restricting? So then your body is saying, man, I'm starving, please feed me. And then you've just gotten into that cycle. Is it a tactile thing? Is this how you emotionally regulate? You do a hand to mouth movement. And then maybe even giving them some sensory guidance in that space as well to emotionally regulate, which the OTs are brilliant for that. But yeah, it's very dependent, but I guess those are the main things that we do.
Yeah, no, that's so interesting and so useful to know, because I would have no idea really. And I think it's good for us as health professionals to kind of get a good understanding of what that should look like. Because, you know, sometimes we are having more frequent or longer appointments with patients, and being able to sort of, empathize with what they're going through and what that journey is going to look like with them is important.
I think concurrently as well, something I didn't mention, family intervention or carer education, or basically educating the entire support network of that person is very, very important. As I said before, it doesn't just impact the patient, it will impact everyone. And if you're not educating the family on what's going on and why that person is really moody or not wanting to talk to you or getting the shits at you because am I allowed to swear on this podcast? I didn't know.
Yes.
Getting the shits at you because you're getting angry at them around meal times, or because they're not eating, and it just causes a lot of havoc within that environment. So educating everyone is also a part of our therapy plans as well, as much as possible, particularly as well in the neurodiverse space with an NDIS participant. Educating, what I try to do is I try to educate all the support workers in every support worker that I can get my hands on, because they are with that neurodiverse individual for most of the day, cooking their meals, talking to them about food, talking to them about life, increasing their social skills. And if that support worker is inappropriately discussing or causing, I suppose, harm through inappropriate discussions around food and what's currently going on for the participant, then it's just not going to have good therapeutic outcomes. So that would be another area that we would look into.
Yeah, that's so useful. That's so good. Blake, do you have any other questions for Bronte?
No, that was great. I'm still processing a lot of this information because it's all relatively new, which is awesome. Like we actively seek out lots of information and research and talk to lots of people, and a lot of this has been new, which is good, which is really good.
Yeah, absolutely. And it's probably more common than any of us I'm sure you're well aware, Bronte, but probably more common than Blake and I are even aware of, and something that we could be better at identifying. So that's, something that we talk about a lot is, to be a good clinician, you need to be good at identifying problems and how they can be appropriately referred on. So this is something that I'm going to have my antennas up for more, hopefully.
Yeah.
I'm really glad to hear that. I'm glad you guys enjoyed it. To give you numbers, because I'm assuming you like numbers, 4% of the population are suffering with an eating disorder currently, and over a third of adolescents engage in eating disorder behaviours at any given time throughout the year. So
yeah,
wow. Binge eating behaviours have increased fourfold since the late 1990s, and dieting behaviours sixfold. So we're definitely doing something wrong.
Is that social media driving that, or is that the lack of control in the world, do you think?
That's really, yeah.
Can you just answer that $1 million question?
Yeah.
I wish that I had the answers. I think it's multifaceted like everything. I think social media does play a really big role. I don't actually very much like social media, which isn't great because it's not good it would be good to be able to talk about these things more, and we do engage in social media, but every time I'm on there I just feel a little bit sick when I see some things that are being discussed. So yes, I do think it's social media. I think adolescents in particular are being exposed to too much information, misinformation, but just in general too much information. They're having a brain overload every single day, which is causing, some mental health distress. And then, as I said before, an eating disorder usually occurs from lack of control. And if a child is feeling a sense of lack of control, they're going to potentially develop an ED. And yeah, I think social media does some wonderful things, but I also think we need to just be aware of what our kiddies and even ourselves are watching. I think I saw what Kim Kardashian had, like a lollipop that was an appetite suppressant, and she was pushing that for a while. And I just thought, oh, please, come on.
That's horrible. Yeah. That is horrible.
Yeah. Speaking of social media, though, there are some very good accounts out there and well worth following. How can people find you, Bronte?
Yeah, so our Instagram is called Nourished Not Deprived, or you can just Google Nourished Not Deprived and see our website. I suppose I would love to mention that we still bulk bill for dietetics and psychology upon request from GP, and I know that's quite rare, but it's just a value that I hold within myself, and it's something that I will continue to do for the foreseeable future. So if anyone is listening and they do need assistance and they can't find a bulk billing clinician, then yeah, feel free. But yes, and then we have Facebook as well, and I have a LinkedIn. If anyone has any questions at all, my inbox is always open. I would love to be able to help in whatever way I can.
Yeah, and your business is completely online, so anyone anywhere can access you and your team.
Yeah, so we maintain a less than 2-week wait list for all modalities. It's just a policy that I have within the organisation as well. It's nearly killed me to keep up with that the past year, but I just think that we shouldn't be waiting, a significant amount of time for a mental health referral. And yes, anyone can access us. We do contract out of a couple of medical centres around Australia as well. So we do have options for face-to-face, but we're predominantly online.
Yeah, that's awesome.
Awesome.
Well, thank you so much for joining us. We had a great chat, and I'm sure everyone's going to get heaps out of that. And we appreciate the time that you've given to share your knowledge.
Beautiful. Thank you so much for having me.
Yeah, thank you so much for coming on.
Have a good day, guys.
Bye.